Here we come and auditing all of your ICDs. Here we come and auditing all of your CPTs. And may joy come to you, 'cause you can code this case too. And let's get into the case right here. So I thought today it might be fun to actually show how I kind of audit a case and how I formulate some of my findings. One of the first things I always do is check the 1500 form to see what was actually billed out on the claim form. Now later on it might come to light that this was not a provider area, it was Jessica at the front desk, or there was an EMR issue, but really the provider is liable for whatever goes out on the claim form because their name is on it. Now I'm not the best at hand filling in 1500 forms, so I just kind of mocked it up a little bit, but we're mostly going to focus on these diagnosis codes. We're going to assume that everything was signed correctly and that this was billed under a provider. There weren't any split shared or incident to or any of those kind of issues in here. So one of the first things I want to show is that when I'm looking at this note here, the date of service that was billed, and again, we're just looking at the note, so assume the date of service is on here, but this is in 2020, which means that even though it's an office visit, I have to code it based off of the guidelines that existed on October 31st of 2020. Which means I need to use our old, well, they will be outdated guidelines technically as of very shortly. So I'm looking at my office visit, and provider billed it out a 99214. So this is kind of like the first glance I'm looking at, and I'm thinking, yeah, this is probably going to hit a 99214. When you do enough of these, you can kind of tell just by looking at them that they may meet the criteria. But let's see how this pans out. So one of the first things you're going to need is your HPI, and you can do your HPI elements or your status of chronic conditions. And looking at this right away at first pass, I can see this patient's got a lot of chronic conditions. Look, we've got congestive heart failure, diabetes type 2, hyperlipidemia, chronic renal insufficiency. Those are chronic conditions. It looks like they have statuses of them, stable, improved. There's a lot of information here about the status. They're going to check the fasting. Okay, improved. So right there away, I don't even have to check our HPI elements because I've already met the criteria here. I've got our 3 conditions. So we're right there at the highest level we can get because we've got our 3 chronic conditions. Next, I'll check my review of systems. And it looks like this provider doesn't have a template that they're using here. So we might just have to go through and abstract what we can from the history of present illness here. So patient has been doing quite well since last seen. He comes in today with his daughter, has no symptoms of coronary artery disease or CHF. He had follow-up with Dr. X, and she thought he was doing quite well, has no symptoms of hypoglycemia or hyperglycemia, has had no falls. His right knee does pain him at times. Okay, so that we can count for musculoskeletal because he's having some knee pain. Wonders whether he could use, he does use occasional Tylenol for that. He wonders whether he could use a knee brace to help him with that issue. Spirits are good. He has no, spirits are good. We could probably count as constitution. He has no incontinence. Well, I'm going to assume that's GU that we're talking about. Urinary incontinence. His memory is clear, so we've got some psych there. And as is his thinking. Okay, so we've met definitely 2 to 9. We've absolutely not hit a complete. There's no way there's a complete in here, but we definitely have 2 to 9. You may have different thoughts about where those score. That's perfectly fine. That happens a lot in medical coding. You might say incontinence. Well, he has to say urinary or, fecal or whatever. But I would say at the very least, I could say one of them, either GI or GU. So I'll count it under GU. We definitely have 2 to 9 here, though. Past family social history. So let's see here. What do we have as far as past history? Well, we've got meds, and current med lists count as past history. We also have, let's see what we've got here as far as anything. We've got, he's had no falls. That could kind of maybe be history-ish. Nothing really surgical. There's no family history. The fact that he has a daughter doesn't really designate that there's any kind of medical conditions going on in the family, but we definitely have some current history as far as medications and stuff. And even past illnesses, it says that he has these chronic medical conditions. It's following up with, assumedly this doctor and that she thought she's doing well. So there's a minimal enough there that I think I can scrape by some past history, but I'm not seeing anything here as far as social history. There's nothing about where he works. There's nothing about where he's living, anything like that. You know, occasionally you can find something way down here that you may be able to abstract, but for now, I'm thinking we're just getting a pertinent. Now, with the scorecard that I use here, and this is the old Novitas one, you know, if you remember, if you don't have 3 checks in this row, you have to go to the furthest to the left, which means we have a detailed history here. Next, we're going to go to our exam. We have to use either body areas or organ systems. So here's our major findings. We've got constitution because he has the weight. Let's see, what's next? We have blood pressure, OT saturation, afebrile, that's all constitution. JVP is the jugular vein pressure, so that's cardiovascular. It looks like there's a lot of cardiovascular stuff here. You know, no HJR, which is your hepatojugular pressure. S1, S2 are heart sounds, aortic murmurs. We've got abdomen, so we can count abdomen up here, and we can count GI down here. Normal bowel sounds, extremities, no edema on today's examination. So that still counts as cardiovascular, which we've already got. Or we can have, let's see here, no extremities. So that means at least 2. So we can count each extremity times 2, but it definitely doesn't designate how many more, but it does designate a multiple, which arguably is at least 2. He's awake, alert, attentive, able to get up on the examination table on his own. That's still constitution. Able to get up out of a chair with a normal get up and go. Bilateral OA changes of the knee. So that is musculoskeletal. We have some creatinine, it says, is down. So we're going to assume that he reviewed these labs, and we're going to go over to our medical decision making and count this as review of lab tests. Next, we go down to our diagnoses. We have more than 2 chronic conditions here, which is going to be really important. We actually have quite a few. We have congestive heart failure, diabetes, hyperlipidemia, chronic renal insufficiency, arthritis. So assuming that we have at least, assuming that these are all established conditions, because it sounds like this is an established patient, they're coming in for follow-up, we have at least 4 here because we have established problems. It looks like most of these are stable or improved, at least at first glance. Stable, improved, stable. It looks like this might not be. TSH was normal. So this might, I'm not seeing that this is really out of check either. So technically we have 5 established problems here that are stable, but again, the highest really you can get here is 4, so we're at the max at 4. I'm not seeing anything else here indicating that he did any x-rays or studies, but let's take a look. Congestive heart failure, stable on current regimen, continued. Diabetes type 2, A1C is improved. Doing self-blood check, glucose monitoring, continue current regimen, recheck A1C. Hyperlipidemia, at last visit he had 3+ protein in his urine. TSH was normal. That's still a lab study. We will get a 24-hour urine to rule out nephrosis as the cause of his hypertriglyceridemia. In the interim, both Dr. X and I have been considering together as to whether the patient should have an agent added to treat his condition. Specifically, we were considering Tricor. Given his problems with his high blah, 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 we have decided not to engage this strategy. We'll leave it open for the future. So now here's where this gets a little bit tricky. Like he says that he's talked to him in the past. Both Dr. X and I have been considering together, but it doesn't say that it was like during this encounter he had the discussion with this particular provider. So if it wasn't related to this encounter, if these were like historical discussions that they've had, not related to this encounter, that really doesn't count. If he would have put in here, like, I had a discussion with Dr. X, you know, because this could be that he just read a note that Dr. X wrote saying that he's been considering this, and I've been considering together as to whether the patient should have an agent added. Yeah, that to me doesn't say they had a conversation. That to me doesn't say that there was a
discussion of the case with another healthcare provider. That could have been ascertained by notes. So next, let's see, chronic renal insufficiency improved with reduction in dose of Bumax. So we've definitely got some prescription drug management going on here. Chronic renal insufficiency, arthritis, stable. Told the patient he could use extra strength Tylenol up to 4 grams a day, but suggested that he start with a regular dose of 1 to 2. States that he will inch up. With regards to a brace, he stated that he used one in the past and it did not help very much. I worry a little bit about the tourniquet type of effective brace could increase his edema or put him at risk for venous thromboembolic disease. For now, we will continue with the cane and walker. Okay. So here, where I would count this immediately is I'm seeing 2 or more chronic illnesses, stable chronic illnesses, and I am seeing prescription drug management here. So either or, we would meet that moderate. We only need one thing in this row, but either or, we could meet that. I'm definitely not seeing anything that would bump us up to high, though, that we have something with a severe exacerbation or we're doing major surgery or anything like that. So here's where we're going to score number of diagnoses. We've got greater than 4. We have high, our risk is moderate. And then we only have 1 data that we reviewed. There was no x-rays or anything that he was ordering, which... I mean, I guess it doesn't sound like this knee problem is significant enough to do so. But in here, this is not where we need all 3 or we go furthest to the left. This is actually the second to the left. If you look here, it says second to the left if we don't have 2 in the same column. So moderate complexity. So we're at detailed. Oop, I didn't score this out. So 1, 2, 3, 4. 1, 2, 3, 4. So in my jurisdiction, and your jurisdiction could be different, my jurisdiction says that we have to have a 4x4 exam rule in order to hit detailed, and I'm not seeing 4x4 here. I'm just not, especially with that musculoskeletal. There's definitely not more than 1 or 2 things there. So I really think this is more, at least in my jurisdiction, an expanded problem focused. Some of you might say detailed, because if you're going just by the 2 to 7 rule is detailed, or 1 in detail, if you're in one of those areas where they say it has to be 2 to 7, but at least 1 is in detail, I would definitely say that's detailed then, because in this one you can tell there's a lot of different detail about the cardiovascular system. But in my jurisdiction, it would be expanded problem focused. Either way, it's an established patient. We only need 2 of the 3, so I don't think it will make too much of a difference as far as the end of the level. So we've got established patient, 2 of the 3. Detailed, expanded, moderate puts us at a level 4, because that's where we have 2 of these 3. So just going back to my 1500 form, I really think, we hit the CPT here, but I'm not so sure about these diagnosis codes, because we have those assumed relationships between anything with diabetes that says with underneath, and diabetes, and I know chronic kidney disease is one of the ones where I think we have an assumed relationship. Depending on what kind of audit you're doing, sometimes they don't even look at diagnoses. I do. So in that case, I would make some commentary in my audit saying that, diabetes and chronic kidney disease have an assumed relationship under that diabetes with, and that it should be a different diagnosis code. So diabetes with chronic kidney disease is actually E11.22 for type 2 diabetes. And these diagnoses, I think I actually know off the top of my head. So we have congestive heart failure is I50.9, diabetes type 2, then we have to specify the stage if known, which we don't, it'd be N18.9. And hyperlipidemia is E78.5. Arthritis is just the generic one, same as on the super bill, M1990. So the provider was pretty close here, except for that assumed cause and effect relationship. And that happens a lot with EMRs, because what happens is essentially he just types in the EMR congestive heart failure, it spits out a code. Diabetes, it spits out a code. They don't know that there's these assumed relationships, especially with hypertension. That's another big one, that it misses those assumed relationships between hypertension and chronic kidney disease, and hypertension and heart failure. So those are assumed relationships under ICD-10-CM. So this is sort of a basic auditing spreadsheet that you could utilize. Now, in an ideal world, I usually have some sort of software that I use in order to audit cases, but I know a lot of auditors that started out very well doing just Excel spreadsheets for their audit findings and then doing a nice summary together to have that summary of what they did find and where the areas of improvement are. So here's our first case that we're auditing here. This is a location, patient MRN. It's the right data service, 103120. Billing provider and rendering provider are the same. Incident 2 doesn't meet here because we're not billing with a physician and a mid-level provider like a physician assistant or a certified registered nurse practitioner. We are also not doing shared split because this wouldn't even be the right setting for shared split. That has to be done. That can't be done in the office setting. It would be incident 2, and that's not, we didn't have any mid-level providers involved. So here's the code that was billed. There were no modifiers. They billed 1 unit. Was it billed based off of time? Nope. So we don't have our total time. Our level of history, what I would just put here is that we had a D for detailed. Love exam was EPF, expanded problem focused. And our level of medical decision making was M for moderate. I came up with a 99214, no modifiers. There was 1 unit billed. And then comments. So that's where we put our feedback. Now, if the provider hadn't met the criteria, I would maybe say, you know, a level 4 established patient visit requires 2 of the 3 criteria: detailed history, detailed exam, moderate level decision making. And because this had expanded problem focused history and low medical decision making, it only met a 99213, something kind of along those lines. But this one met, but I still want to make a comment maybe regarding the diagnosis coding. So let's see, ICD-10-CM, I don't want that, assumes a relationship between diabetes and chronic kidney disease unless provider documentation explicitly states they are unrelated. Diagnosis, what did I have here? E11.22 should have been utilized based on the specificity. And that's just kind of it. That's how you just go through and do a very basic audit finding. Again, I think, you know, putting together a nice little summary too that says, you know, we audited 10 cases, 2 of them were overcoded, 1 was undercoded, you know, and summarizes a lot of the areas of improvement. That is also, I think, really good and to put into your audit findings. So, but yeah, that's the basics of just kind of how to formulate an audit.
I hope you found this video helpful. If you did, I would really appreciate it if you support the channel by giving it a big thumbs up. Don't forget to subscribe and hit that notification bell so you'll get alerts when I post new episodes. I will see you in the next episode, and until then, just keep on coding on.